All right, let's dive right in today. We're tackling febrile neutropenia.
Oh, an important one for sure.
Especially for us in the medical microbiology world.
Absolutely.
I mean, we see these patients often immunocompromised dealing with chemo.
Yeah.
And then, bam, this condition hits. And it can be so tricky to catch.
It really can.
So we're going right to the source, the WHO.
Okay.
Their aware book, specifically Chapter 39.
All about antibiotics, right?
You got it. Responsible use, the latest guidance.
Gotcha. So are we going to, break it all down?
That's the plan. Diagnosis, treatment, everything a microbiologist needs to know.
Sounds good. I'm ready when you are.
Okay. First things first, how does the WHO even define febrile neutropenia?
So there are two key pieces to this puzzle, right?
Okay.
Fever, which is a single oral temp of 38.3 degrees Celsius or higher.
Okay.
Or 38 degrees Celsius for a whole hour straight.
Got it.
And then neutropenia, which means the absolute neutrophil count is below 1,000.
1,000 cells per microliter, to be precise.
Exactly. And it's not just about hitting that number, it's also about how low it goes.
Different levels of severity.
Yep. So you've got severe, which is less than 500.
Okay.
And then profound, which is anything under 100.
Wow. Those are some big distinctions.
They really matter for assessing risk and figuring out the best treatment plan.
That makes a lot of sense. So we're not just looking at yes or no for fever and neutropenia, but also the degree of neutropenia.
You got it.
Now, let's move from the textbook definition to the real world.
Okay.
How do we actually characterize febrile neutropenia in practice?
So the WHO, they break it down into 4 ways.
Okay, lay them on me.
First up, you've got microbiologically proven infection. We find the actual bug through cultures.
Gotcha. So like a positive blood culture.
Exactly. Then there's a clinically diagnosed source, but no pathogen.
Okay, what would that look like?
Say pneumonia. You see it on the chest x-ray.
Okay.
But all the cultures are negative.
So you know something's there,
Yeah.
but you can't pinpoint it exactly.
Exactly. Third, unexplained fever.
Okay.
No clear signs, no positive cultures, a real head scratcher.
Those are always tricky.
And last, non-infectious fever.
Meaning the fever isn't even from an infection.
Right. It could be a drug reaction, or maybe tumor lysis syndrome, things like that.
Okay, those 4 categories are super helpful, really helps paint a clearer picture.
Yeah.
But how does this all actually manifest in patients? What do we actually see?
Well, that's where things can get a little, weird.
Weird how?
The typical signs of infection, the redness, the swelling.
Right.
Sometimes they're totally absent, or just really, really subtle.
Why is that?
It's because their neutrophil count is so low.
Okay.
Their body can't mount the usual inflammatory response.
Oh, I see.
And get this, sometimes they don't even have a fever.
Wait, really? No fever?
Nope.
So how are we supposed to catch this if they don't have the typical signs?
We have to be hypervigilant.
Looking for what exactly?
Anything out of the ordinary. A rapid heart rate, low blood pressure.
Signs of sepsis?
Exactly.
Septic shock?
Yep. Change in mental status, difficulty breathing, anything like that.
This is serious stuff.
It is, and it can progress so quickly.
Wow.
Early detection is absolutely critical.
Okay.
It's super critical.
Okay, this is where our job as microbiologists becomes super important.
I was just thinking that.
We need to guide these clinicians, make sure they're ordering the right tests, and fast.
Exactly.
And the WHO, they emphasize this big time.
What do they say?
Get those microbiology tests done before starting antibiotics.
Oh, that's smart. Why?
So we can pinpoint the exact culprit
Okay.
and avoid using broad-spectrum antibiotics when they're not needed.
Because of resistance.
You got it.
That
We don't want to fuel that fire.
makes sense.
So what are the must-do tests, no matter what?
Blood and urine cultures, those are non-negotiable.
Right.
Our first line of attack.
Okay, those are a given. But what about other tests? When do those come into play?
Well, it depends on the presentation, right?
Right.
Respiratory symptoms,
Okay.
sputum microscopy and culture, plus a nasopharyngeal swab.
To look for viruses?
Yep. Influenza, SARS-CoV-2, all that good stuff.
Right, of course.
Meningitis. We're going for a spinal tap.
CSF testing. Got it.
Stool cultures are crucial too,
Why?
to rule out C. diff, especially if they've been on antibiotics.
Makes sense.
Anything else?
For those high-risk patients, or if the fever just won't budge.
Okay.
We got to think about testing for those invasive fungal infections.
Oh, right. And other viruses too, I imagine.
Exactly.
So it's all about tailoring the testing strategy to the specific patient.
That's the key. Risk factors, presentation, the whole picture.
And speaking of risk factors, the AWARE guidance talks about low risk and high risk patients.
Yeah.
How do we decide who goes where?
Low-risk patients, they're the ones with neutropenia that's expected to last less than a week.
Okay.
No major health problems besides the cancer.
Right.
And their organs are functioning well, so they might be able to be managed as outpatients.
Potentially. Oral antibiotics.
And lots of monitoring, I'm sure.
Of course. High-risk patients are different.
How so?
They're looking at neutropenia for more than 7 days.
What?
Maybe they have other health conditions on top of the cancer?
Comorbidities?
Yeah, or their organs aren't working as well as they should.
So those are the ones who likely need hospital admission.
Usually. And IV antibiotics.
Okay.
It's all about, tailoring the treatment to the individual patient.
Absolutely. Makes a ton of sense. Now, besides those microbiology tests we talked about,
Yeah.
what other lab tests can help us out here?
Well, you always got to start with the CBC.
Of course.
Yeah.
To see how bad the neutropenia is.
Exactly. But also to check for anemia, thrombocytopenia.
Right. Got to look at the whole blood picture.
Yep. And then liver and kidney function tests.
Okay.
Electrolytes, blood pH, gases. Got to make sure those organs are holding up.
And what about lactate?
Lactate, yeah.
Yes,
It
ma'am.
tells us about tissue perfusion, how well the blood is flowing, and inflammatory markers.
Like CRP.
Free therapy, procalcitonin.
So all these tests, they're not just about the infection itself,
Right.
but also about the patient's overall condition.
Exactly, how their
Yeah.
body's coping with everything.
Okay, that makes a lot of sense. What about imaging? Does that come into play?
Absolutely.
When is it helpful?
Well, right at the beginning, it can help us find the source of the infection.
Right.
Like if we suspect pneumonia, a chest x-ray is a must.
Makes sense.
And if the fever's sticking around despite treatment, further imaging might be needed.
Looking for what?
Complications, maybe?
Okay.
Or sometimes an alternative diagnosis, like invasive fungal disease.
So imaging, it basically helps us visualize what's going on inside.
Exactly.
Helps guide those treatment decisions.
You got it.
Now, before we jump into the treatment guidelines from the AWARE book,
Okay.
let's take a step back
Okay.
and talk about why these patients are so susceptible to infection in the first place.
Well, it all comes down to the neutropenia itself.
Right.
Neutrophils, those are our frontline soldiers.
Fighting off bacteria and fungi.
Right. And when their numbers drop, our immune system takes a big hit.
Makes them vulnerable.
Totally. Even to bugs that wouldn't normally cause any problems in healthy folks.
So it's not just about the presence of pathogens, but also about the body's ability to fight them off.
You got it. And the severity of the neutropenia, how low it goes, that really matters.
And how long it lasts.
Yep.
Makes sense. So the lower the count and the longer it stays low, the higher the risk.
Right. And then, of course, there's the cancer treatment itself.
Chemotherapy.
Yeah, it's like a double-edged sword.
How so?
It kills those cancer cells, which is good,
Great.
but it also whacks the bone marrow.
Oh, no.
Meaning less of all the blood cells, including those neutrophils.
So that's why chemo-induced neutropenia is so common.
Exactly. It's a big concern for these patients.
It's like the very treatment that's meant to help them also puts them at greater risk.
It's a delicate balance.
It really is. And it's not just chemo, right?
Nope.
Other health problems can play a role.
Absolutely. Certain medications,
Okay.
and even things like catheters, anything that compromises their defenses.
It's complex.
It is. Managing these patients.
You really need a whole team.
Exactly.
Well,
Doctors, nurses, pharmacists.
And of course, us microbiologists.
Absolutely. We're key players.
Before we move on to those antibiotics, I'm curious about how common febrile neutropenia actually is.
It's more common than you'd think.
Really?
Febrile neutropenia. It's actually the most common complication of those cytotoxic cancer treatments.
Wow.
But the risk, it can vary a lot.
Based on what?
The type of cancer,
Okay.
the chemo regimen they're on, their age, the stage of their disease.
So many factors.
Oh, yeah. And if they have other health problems or are on other medications, it all adds up.
So some patients are at much higher risk than others.
Exactly. And that's why this risk stratification is so important.
So we can be more proactive, especially for the most vulnerable.
Totally. Now, before we get into those antibiotic treatment strategies,
Okay.
we got to talk about the usual suspects. The microbes themselves.
Who are we dealing with in these cases?
Well, often it's those bugs that are already living on or inside the patient.
Opportunistic infections.
Exactly. And the AWARE book, they've got a whole list
Oh, yeah. Yep.
of the most frequent culprits.
Okay, let's hear it.
All right, so bacteria first. The number one bad guy, Staphylococcus epidermidis.
Classic.
Then you've got Staphylococcus aureus, including MRSA,
Of course.
Streptococcus species, Other gram-positives like enterococcus?
Including VRE?
You bet. Can't forget about those.
And what about the gram-negatives?
Oh, they're in the mix too. Enterobacterales, those are big ones.
Especially the multi-drug resistant ones, right?
You know it. The ESBL producers. The carbapenemase producers, they're a real pain.
They are. And Pseudomonas, I'm guessing.
Oh yeah, Pseudomonas aeruginosa. Always got to watch out for that one.
It's like a whole rogues gallery of pathogens.
It is. And if the neutropenia sticks around for a while...
Things get even more interesting.
Right. Anaerobes can become a problem. And fungi.
Candida.
Candida, for sure. Aspergillus, too.
Okay.
And viruses, cytomegalovirus, human herpes virus 6, they can all take advantage.
It really highlights how important those microbiology cultures are.
Totally agree.
We need to know exactly who we're fighting.
Exactly. And don't forget about those local resistance patterns.
Oh, right. Essential information.
It is. Knowing what's common in your area, what those bugs are resistant to.
Helps us make the right choices about treatment.
Absolutely. We don't want to be throwing antibiotics around blindly.
Nope. We got to be smart about it. Strategic.
Exactly. So, armed with all that knowledge, how does the AWARE guidance actually tell us to treat febrile neutropenia?
That's what I'm really interested in. I'm always eager to see how these guidelines evolve, you know, especially with antibiotic resistance being such a huge issue.
They've taken a really practical approach.
Meaning?
They get that one size doesn't fit all.
Okay.
Different recommendations for adults, children.
Makes sense.
Taking a risk into account, local resistance patterns.
So we're not just blasting everyone with the strongest antibiotics we have.
No. It's much more targeted.
Okay.
Use the narrowest spectrum antibiotic that'll actually work.
Based on the patient's presentation, their risk, what's circulating in the community.
Exactly.
Sounds a lot more responsible. More sustainable, too, in the long run.
It is.
Can you walk me through the recommendations for adults?
Sure.
Let's start with those low-risk patients.
Okay, so for them, the first choice oral antibiotic is amoxicillin clavulanate.
Okay, good old Augmentin.
Yep. Every 8 hours.
What's the dose?
500 milligrams of amoxicillin, 125 of clavulanate.
Good coverage against a lot of the usual suspects, right?
Yeah, it hits a lot of those gram-positives, gram-negatives, even some anaerobes.
Now, what about if those resistant bugs are more common?
Like those ESBL-producing enterobacterales. The AWARE folks, they suggest adding ciprofloxacin.
Okay, to broaden the coverage.
Yep, 500 milligrams every 12 hours.
So you're tailoring the regimen to the local resistance patterns. Smart. Now, what about those high-risk adults?
The ones who usually need to be in the hospital.
Yep, the ones on IV antibiotics. What do they get?
For them, it's piperacillin tazobactam.
Okay, that's Zosyn.
Right, you got it. 4 grams of piperacillin, 500 milligrams of tazobactam every 6 hours.
Good guns.
Got to hit them hard. Broad spectrum coverage, gram-positives, gram-negatives, anaerobes.
Okay, but what if they have a history of those resistant bugs? Or if they're just really common in the hospital?
In those cases, meropenem is an option.
Oh, okay, a carbapenem.
Yep. A gram every 8 hours hits those ESBL producers pretty well.
So again, you're escalating therapy based on the risk and the local patterns.
Exactly.
Are there any other antibiotics that might get added on?
The AWARE guidelines say you could think about amikacin.
Okay, for what?
If those resistant gram-negatives are a big worry.
Those ESBLs, carbapenemases?
Exactly. 15 milligrams per kilogram a day. And if MRSA is a concern, you might add vancomycin.
Ah, okay.
15 to 20 milligrams per kilogram every 12 hours.
Wow, they're not messing around. So you're hitting these infections from all angles.
That'd be aggressive.
What about how long these antibiotics are given for?
Ah, good question.
Traditionally, we've always waited until the neutrophil count recovered.
That's how it used to be. But there's new evidence.
Oh, what does it say?
It might actually be safe and effective to stop the antibiotics sooner.
Really?
Yep, based on how the patient's actually doing.
So if they're getting better, no more fever, signs of infection gone, we can stop.
Even if their neutrophils are still low.
Right.
Exactly.
That's pretty interesting.
It is. It helps reduce how much antibiotic exposure they get.
Less chance of resistance developing.
Right. And fewer side effects.
It's a win-win.
It is. But of course, you have to watch them closely.
Make sure the infection doesn't come back.
Exactly. This whole idea of clinical guided discontinuation.
It's a big shift.
It is. It's about using antibiotics more judiciously.
I like it. I'm sure patients do too.
They do. Shorter treatment time.
Less burden from the meds.
Yeah.
Now, I know this AWARE guidance is all about antibiotics.
Yeah.
But are there any other treatments we should be thinking about?
Well, there are those granulocyte colony stimulating factors.
DCSFs?
Yep.
They boost neutrophil production, right?
That's the idea.
So do we use them routinely?
That's actually kind of controversial.
Oh, why?
They might shorten hospital stays, maybe reduce how long you need antibiotics.
Sounds good.
But they haven't been shown to actually reduce mortality.
Really?
Nope.
Interesting.
So whether to use them or not, it really comes down to the individual patient,
Okay.
their risk factors, their clinical situation.
Sounds like a conversation to have with the whole medical team.
Absolutely. A shared decision.
Okay, I think I'm ready to put my knowledge to the test.
All right, exam time.
Hit me with those questions.
All right, first question. Define febrile neutropenia.
Okay. Give me the specifics. The criteria for fever and neutropenia.
Febrile neutropenia is defined as a fever, which is a single oral temperature of 38.3 Celsius or higher,
Okay.
or a temperature of 38 Celsius that lasts for an hour, plus neutropenia,
Which is?
an absolute neutrophil count of less than 1,000 cells per microliter.
Perfect. You nailed it.
Nailed it.
You really understand that precise definition.
It's important.
It is. For diagnosing it right, figuring out who's at risk.
Okay, what's next?
All right, question 2. Remember those 4 ways to characterize febrile neutropenia in practice. Describe them and give me a real-world example for each one.
Okay, so first you have microbiologically proven infection, meaning you actually find the bug, like through a blood culture.
Give me an example.
So imagine a patient with pneumonia. Their blood culture grows Streptococcus pneumonia. That's microbiologically proven.
Okay, good. What's next?
Then there's clinically diagnosed source, but no identified pathogen. So maybe they have cellulitis. Classic signs and symptoms.
Yeah. But all the cultures are negative. Then there's unexplained fever.
The mystery fevers.
Yeah. Fever, but no other symptoms. All the initial tests are negative. And finally, non-infectious fever.
Where something else is causing the fever.
Right. Like a patient with leukemia who develops a fever because of tumor lysis syndrome.
Great job. You really know your stuff.
Thanks.
It's important to remember that not every case is going to be straightforward.
Oh, yeah, for sure.
Sometimes we got to manage those patients even when we don't have all the answers right away.
Absolutely.
Yeah.
It's all about that clinical judgment.
It is. Careful monitoring. And being ready to reassess as we get more information.
Hit me with question 3.
All right, this one's about those microbiology tests, the essential ones.
Okay.
Which ones are we talking about? And why is it so important to get them before we start antibiotics?
This is key. Blood and urine cultures. Those are the absolute must-haves.
And why before antibiotics?
Because we need to know exactly what bug we're dealing with. So we can give the most targeted antibiotic therapy. If we start antibiotics first, we might never find the true culprit. And we could end up using broad-spectrum antibiotics when they're not even needed.
That's right. It's about being a good steward of these precious antibiotics.
Exactly.
Empiric therapy is important, don't get me wrong.
Right. These patients can get sick fast.
But we got to get those cultures first. It's the only way to make sure we're using the right antibiotics for the right bug.
Makes sense. It benefits the patient and helps preserve those antibiotics for the future.
Exactly. All right, you ready for a real-world scenario?
Bring it on.
Okay, imagine this. You get called about a patient with newly diagnosed acute myeloid leukemia.
Okay.
They've just had their first round of chemo, and now they have a fever. And neutropenia.
Classic presentation.
Yep. Their neutrophil count is expected to be down for 10 days.
Okay.
They're clinically stable, no other health problems besides the leukemia.
Okay, so which antibiotic do we start?
That's the question. What do you think?
Okay, let's think this through. They're high risk, right? Neutropenia for more than 7 days.
Good thinking.
But clinically stable, no comorbidities. So I'd say we start with IV piperacillin tazobactam.
Okay, good choice. Why that one?
It's broad spectrum, covers those gram-positives, gram-negatives, even the anaerobes. Seems like a good empiric choice for a high-risk patient like this.
Excellent reasoning. You're on fire.
Thanks.
You've got those risk factors down, Pat. And you're choosing those antibiotics like a pro.
Okay, so let's say they get admitted. They're started on the Zosyn. 3 days later, their fever's gone. Vitals are stable. Exams normal.
Sounds good.
But their neutrophil count is still low. What do we do about the antibiotics?
What do you think?
This is where that clinical guided discontinuation comes in, right?
Go on.
Even though their neutrophils are still down, they're clinically improving. So I'd say we stop the piperacillin tazobactam. We watch them closely, of course, make sure the infection doesn't come back.
Yeah.
But this way, they're not on antibiotics longer than they need to be.
You got it. You're really getting this.
It just makes sense.
It does.
Okay, hit me with the last question.
Okay, last one. Why do we have to think about those local antimicrobial resistance patterns when we're choosing empiric antibiotics?
That's super important. Those patterns, they're different everywhere.
Right.
What works in one hospital might not work in another. If we don't choose an antibiotic that covers those resistant bugs in our area, treatment could fail.
Exactly.
It could even be life-threatening. We, as microbiologists, we have to stay informed. We got to guide those clinicians.
You're absolutely right. Knowing those local patterns is crucial. It's not just about the guidelines, it's about applying them intelligently in the real world.
It's about thinking critically.
Exactly.
It's amazing how much our understanding of febrile neutropenia has changed.
It really is.
We've come a long way
Yeah.
from just like reacting to these infections
Right.
to really getting proactive, thinking about risk,
Yeah.
tailoring the treatment.
To the individual patient
Exactly.
and to what's happening in their community.
It really shows how important it is to stay current
Oh, absolutely.
with the latest research, guidelines.
You got to keep learning.
You do. And it's not just about reacting anymore. It's about, like, thinking ahead.
Preventing these infections in the first place.
Ah, that's a great point. Especially with all these multi-drug resistant bugs out there. This aware guidance, it focuses on treatment, but what about prevention?
It's a big question.
These patients are already so vulnerable. What can we do to protect them?
Well, for starters, we could tighten up those infection control measures,
Okay.
especially in the hospital.
So hand hygiene,
Oh, yeah, that's crucial.
environmental disinfection,
Making sure those surfaces are clean,
being really careful with catheters,
all those invasive devices.
because they're basically a direct line for those bugs to get in.
Exact.
So those are all standard practices. But maybe we need to be even more strict with these patients.
Maybe so. And then there's prophylactic antibiotics.
Oh, okay. Giving antibiotics to prevent infection?
Exactly.
Does that work?
Well, it might be helpful for those really high-risk cases.
Okay, so.
Those patients getting super intense chemo.
Right.
Or the ones with neutropenia that just drags on and on.
A short course of antibiotics might help prevent things.
Potentially.
But what about the risk of, driving more resistance?
That's the big concern, right?
It is. We don't want to make the problem worse.
We don't. That's why you got to be really careful.
Okay.
Pick the right patients,
Mm-hmm.
the right antibiotics.
And not give them for too long.
Exactly. And that's where we come in.
Microbiologists.
We can help guide those decisions.
Make sure it's done responsibly. So prophylactic antibiotics, they're a possibility. But there are downsides. Any other maybe newer approaches out there?
There's some really interesting research on the microbiome.
Oh, the gut bacteria. How does that play into this?
Well, the idea is to, manipulate the microbiome.
Yeah.
In a good way, of course.
One listening.
You basically encourage the growth of good bacteria.
The ones that can outcompete the bad guys.
Exactly. And maybe even help boost the immune system.
So it's like giving their own microbiome a fighting chance.
That's the idea. It's still early days.
Oh, okay.
A lot more research is needed.
But it's promising.
It is. Imagine being able to change the gut microbiome to help fight infection.
Wow, that would be a game changer.
It would. And not just for neutropenia.
Oh, you're thinking bigger picture.
For all sorts of immunocompromised patients. It's a whole new frontier in infection prevention.
Moving beyond those traditional methods.
To something more personalized.
More targeted. It's really exciting. This deep dive has been incredible. I've learned so much. I feel much better equipped to deal with these cases now.
That's great to hear.
We covered it all.
We did.
From the basics of what febrile neutropenia even is, to those up-to-the-minute treatment guidelines, and even those cutting-edge prevention strategies.
It's an evolving field.
It is.
So always keep learning. Stay curious.
Couldn't agree more.
The aware guidance, it's a great starting point.
It is.
But keep reading those research articles, those clinical trials. There's always something new.
Absolutely. Well, thank you so much for joining us today, for sharing all your expertise.
My pleasure.
And to all our listeners, thanks for tuning in. We hope you found this deep dive into febrile neutropenia informative, and maybe even a little bit inspiring. Keep those minds sharp and those cultures growing